look for any abnormality. Also, we are going to talk about the importance of supplementary windows while doing
Audio is slow.
Yeah.
Audio is slow.
Okay. Okay. So we'll be seeing that today our class, topic will be looking at the variations of the normal brain in the newborn and also the various supplementary windows that are available in addition to the foramen of anterior fontanel, where we're going to do the neurosonogram and how they are going to be useful in making a diagnosis. So I think it'll be mainly a recap of what we have done so far, mainly the neuroanatomy. And I think it's nice to go through it because there has got Prashant has got excellent pictures and it gives a real 3D image. So without much delay, I think I'll hand over to Dr. Prashant for his this talk on neurosonogram, normal variations and supplementary windows. Thank you, sir.
Yes, sir. Thank you. I would like to thank NNF Tamil Nadu for the opportunity, and I would like to thank Kamal sir and Lakshmi Madam, Reema Madam for giving me this opportunity and the entire team of ICH. So as I said, the heart of medicine is always anatomy. So the anatomy takes some time for us to register in our brain. So there is a quick recap which I'm going to do now. I hope my voice is very clear. If you find any disturbances or if you're unable to see my slide properly, please let us know. I have logged in 2-3 different mobiles so that I'll be able to get an idea about if there is any problem. So quickly I'll recap. So we are talking about the brain. So in the last class, we just spoke about the normal anatomy of the brain, sonographic relevant anatomy of the brain. So frontal lobe, parietal lobe, temporal lobe, and occipital lobe. These are the external anatomy. Then we played this thing, how the reconstruction of brain from inside to outside happens. So first you have to place the ventricle. So the ventricles has got lateral ventricle. Both are connected by foramen Monro with third ventricle. Then they are connected to fourth ventricle by aqueduct of Sylvius. So, and lateral ventricle has got anterior on, body, occipital or inferior or temporal on. Then we try to place the nucleate, that is deep cortical nucleate, that is the thalamus, which is placed adjacent to the third ventricle. You can see on either side of the third ventricle placed in each cerebral hemisphere, thalamus is there. Now, after thalamus, we will try to place the caudate nucleus. The caudate nucleus has got head, body, tail of caudate nucleus, so which will encircle superiorly around the thalamus between anterior on and the thalamus. So below the anterior on of the lateral ventricle, you have caudate nucleus, and below that you get thalamus. So we are trying to reconstruct the image. This is how it looks like from the inferior surface, from the frontal view. So there is third ventricle, thalamus, between lateral ventricle to third ventricle, you have caudate nucleus. Now we have placed internal capsule where you see crossing over of the fibers. So this is placed between after the thalamus, caudate nucleus, and between the inferior horn of the lateral ventricle. Now we are trying to place the other parts of basal ganglia, that is globus pallidus interna. This is the interna, which is placed, then externa. After externa, you get putamen, one more. As last time I described you as a cream biscuit. So the cream is your externa. Inside you have first you have interna, externa, and then putamen. So this is how the interior of the inside part of the brain, which looks like. So now we are trying to, there is a connection which is established between the lenticular nucleus and putamen. So we have neostriatum, we have lenticular nuclei, different terminology for this basal ganglia system. So now caudate nucleus has been connected, piercing the internal capsule to putamen, and globus pallidus also is connected. So that's why we call it as a complete basal ganglia system. So there is a ventricular system, basal ganglia system, and a limbic system. So I hope this is the superior surface. We are trying to reconstruct how it looks, and we are trying to label the structures. You can see here now how it looks. Putamen, which is the green one, then globus pallidus from lateral to medial. Then you have your internal capsule. Then you have your thalamus, and superiorly above the thalamus you have your caudate nucleus, head and tail of the caudate nucleus. This is how exactly the inside of the brain, the center of the brain or the heart of the brain looks like. So when you take a cut section of the brain, these are the parts. You have first you have putamen from outside next to the sylvian fissure. Then you have globus pallidus after putamen. Then you have internal capsule. Then inferiorly you have thalamus. Then superiorly to thalamus, below the lateral ventricle anterior arm, you have your caudate nucleus. I hope these structures are very clear. So when you are talking about the normal variation, you need to know the structure names and where it is placed, ventricular system, and then it will be easy for us to understand the normal variation which we see when we do the scan. So this is the transverse section which we have taken. This is not an ultrasound image; it's an MRI image, but to get you an idea about the structure. So this is how exactly it looks like. So we have gone again. So this is how it looks. Now, this is an interesting thing, which is a geometric, which I said there is a brainstem. You can see the prominence with the purple color is your thalamus. Above the thalamus, in between two thalamus, that is, see, there is a third ventricle. Then you have thalamus on either side. Just above, in between the thalamus, you have your fornix. See how it goes, like encircles, how it encircles. You see the first diagram first. So the two cubes, what you are seeing is your thalamus. If you come to the second one, let me pause the second one. Let me run the first one first. So this is the corpus callosum. You can see from above to down, if you take, you have corpus callosum. Then you have cavum septum pellucidum, which will come in between fornix and corpus callosum. And fornix is placed in between two thalamus. And below that, you get your third ventricle. So when you take a sagittal section from top to bottom, if you take, you have your cerebral cortex, cingulate gyrus, corpus callosum, then you have cavum septum pellucidum, then you have fornix, then third ventricle, and if you tilt a little bit, then you will see the thalamus part. And then you have your brainstem, that is midbrain, pons and medulla. This is how it looks. So it is important for you to understand the relationship of fornix, corpus callosum, thalamus, and third ventricle. So let me run the second. So here you can see the attaching to the thalamus, there is an hypothalamus, which is a V-shaped structure with a stalk, which will get connected to the hanging structure, that is your pituitary gland. So anteriorly it is placed, anteriorly and inferiorly it is placed. All right. So let us run the second video. So from top, there is a corpus callosum. Then you have cavum septum pellucidum, which is marked in green color. Then below that you have your fornix. Below that you have third ventricle. On either side of the third ventricle you have your thalamus. This is how the structure of the brain. Now we have attached the hypothalamic stalk, and which will through which your pituitary gland will hang. So I hope it is very clear, the sequence from top to bottom. Now we'll move on to the another 3D picture, which is important for you to understand. You can see thalamus and interthalamic adhesion between the two thalamus. Then we are turning here. So below anterior and inferior, you can see hypothalamus. And below that, you can see a cherry-like hanging thing, that is your pituitary gland. Can you see the hanging one here? Hanging one, that is your pituitary gland. Now again, we are showing the thalamus. Then we are showing the hypothalamus. Then we are going on the dorsal side, that is the pineal gland. On either side of the pineal gland, you have your colliculus, which sits on the roof of the midbrain, that is your tectum. Then you have your pons, medulla oblongata, which will continue. So now, quick recap, how it looks. With the cerebral hemisphere, we have removed one part of the cerebral hemisphere. From inside to outside, you have your anterior of the lateral ventricle, then you have caudate nucleus, then below you have your thalamus, then you have your globus pallidus interna, externa, and then putamen. you can see the connection between the caudate nucleus and the thing. Now arrow mark I'm showing thalamus. Now it is hypothalamus. You can we have turned backwards. We are seeing the colliculus, which is sitting on the tectum of the brain. That forms the roof of the midbrain. Then we are rotating on the lateral side. You can see the hanging structure below the hypothalamus is your pituitary gland. This is your pituitary gland. So basal ganglia, limbic system, and ventricular system. So this is your hypothalamus. This is your putamen. This is your part of the thalamus. This is your hanging one. This is your pituitary gland. So this is your anterior arm. You can see. Then you get your caudate nucleus. Then you get your putamen. So this is the biscuit which I was talking about. This is your globus pallidus interna and externa. Clear? Now let us move on to the today's topic. So can you wait? Are we seeing? One second. Let me stop sharing. Give me a minute. I'll start with today's topic. So now we'll be moving to the today's topic. I'll start sharing today's topic slide. Yes, normal variants. So a brief introduction I've already given about the structure. So normal versus abnormal. Which are the things? These are the few measurements. I usually don't mug up. I just take a printout and put it in the NICU, or I keep it along with the machine so that it is easy. You don't have to. If you keep on doing the scans, then you'll start remembering the measurements. So these are the few measurements which will help us in understanding what is normal and what is not normal. I request any of your postgraduate just to unmute and read this ultrasound image. Even if you make mistake, it's fine. Please don't worry. I have marked few things here. Can any one of you unmute and start reading like an X-ray? I told you last time how to read the sonographic image. From head below, you have placed a probe. So first section, Kamal sir, any of the PG can unmute and start reading the thing, because it is very important for you to, once you start speaking and reading, it's easy for you to understand. Any of the PG is there? Can you please unmute? I will help you, don't worry. Any voluntary PG is there? Any of you? Yeah. Anybody who has volunteered? I can see Dr. Tanvir. Yes, Dr. Tanvir.
Yes, sir. Good afternoon, sir. The first session is a sagittal section, sir.
Yeah.
Showing a part of corpus callosum, sir.
Okay.
Then.
So I would always tell that you see you have place a probe on the anterior fontanelle, correct? So it's a sagittal section. It is you feel this is a mid sagittal section or parasagittal section?
Parasagittal, sir.
Parasagittal. So when you say parasagittal section, you see corpus callosum or you don't see corpus callosum?
I don't see corpus callosum, sir.
Exactly. Corpus callosum is always in the center, mid sagittal section when you take. So this is the parasagittal section. So from beginning, you see, yeah, layers of the skull. The first below, immediately below the probe, you see layers of skull, skin, and layers of skull. Then you
And
start
then cerebral.
seeing here you can't, yeah, meningeal covering is not very clearly, correct? Then you see your cerebral cortex. Do you see what do you see in the first image in the cerebral cortex? What do you feel could be the age of the baby? Looking at the image.
Sir, there is a periventricular flare, sir.
Okay, but we will come later there. We'll come on the abnormal finding later there. First, you tell me what based on this age, do you feel this baby is mature or premature? This image of the brain, what you are seeing, does it belong to a mature baby or an immature, premature baby?
Premature, sir.
Very good. Why premature?
Sir, it it is hyper.
Yes, see, the most important thing is in a premature baby, the brain is like a mushroom, clean, smooth. I mean, your sulci, gyri will be very, very minimal.
Yes,
Can you see a lot of sulci and gyri in this?
no, sir. It's not visible, not clearly visible.
Exactly. So there is something called as, see, the cingulate gyrus which you see above your corpus callosum, correct? So that usually appears between 24 to 28 weeks. So if you are not the cingulate gyrus, it could be an extreme premature baby image. So one is sulci and gyri. So you see the image from top to bottom. You see the skin, layers of skull. Then below that you see the layers, meningeal covering, your dura mater, arachnoid space, and pia mater. Pia mater is the one which hugs the brain surface. So
Sir, how
and then yeah.
changes, sir?
Sorry.
I couldn't make those, sir. I can know that.
Yeah. Image you cannot make. I'm just telling you the order. If you go with very high frequency probe, you can see the differentiation also.
Okay, sir.
Hockey stick probe if you go. Just to give you an idea about how to read it, you have to check whether you can see all this. Then you see the how much sulci gyri, status of the cerebral cortex. Then you come to the ventricle. Then you come to the your thalamus and other things. Then you see like how you see in X-ray whether there is echo densities are there, whether there is any flare up is there, what we call, or whether there is you see any obvious cyst or obvious abnormal pathology. So in this image, you feel it is a premature baby brain image. You can see a slit of lateral ventricle, but parietal and posteriorly to the your anterior horn of, lateral ventricle, you can see a periventricular, correct? So now you have to see one more important thing, that is the other section. That is always abnormal finding in ultrasound has to be checked in two different planes, if possible, two different windows.
Yes, sir.
All right. So you can see there is a overall, it looks more whitish. The entire picture looks more whitish. So one thing that extreme premature baby, the neuronal cells will have lot of cytoplasm, so which will reflect more echogenic. So there is a difference between physiological echo density versus pathological echo density. So the most of the pathological physiological echo density usually disappears within 7 days. That's why you need to repeat a scan after 7 days and see whether the echo density has persisted or not. If it persists and if you don't see any improvement in echo density, that is pathological. For you to counsel the parents, this is one of the key features. So in this image, you are right, you're feeling a periventricular flaring, but it's a premature baby. That means you have to keep in mind about the premature neuronal cells with lot of cytoplasm, which can deceive you saying that periventricular flare or periventricular density. Good. I think that's a fantastic thing. So I request everybody, PG, to make an attempt to tell whether it is right or wrong. Don't worry, nobody is judging you. So this is the mid-sagittal section you are seeing. Can you see corpus callosum here?
Yes, sir.
Yeah, you can see corpus. Below corpus callosum, you see one structure. What is that structure? We just,
So that is septum pellucidum.
yeah, Anteriorly, you have your cavum septum pellucidum. Posteriorly, Purgai and interpositum, posterior to the thalamus or yeah. These are the three parts. So this part, what we are talking about, is one of the variants. So you see sometimes only anteriorly, sometimes you see in the middle, sometimes you see here. All right. So this, if you see the same baby's brain image, mid-sagittal section, but you can see a lot of hyperemia, but very less sulci and gyri. So convolution is very, very minimal. So in this image, you can also see what is this? What is this?
Cerebellum. Cerebellum.
Very good.
Vermis and
yeah. You can see vermis in mid-sagittal section a bit and cerebellar hemisphere. What is this? What is this?
This is the cerebellar hemisphere.
Below that, what you get? What is this?
Cisterna magna.
Yeah, it is at the exit. Yes, it is at the exit of your skull, cisterna magna. After cisterna magna, below that, whatever you see, you're seeing little bit of spinal cord here. Correct?
Yes, sir.
This is your medulla oblongata. Then you have your pons. You can see the shape of the pons here.
Midbrain.
Yes, coming. So this is your midbrain. Then you have your yeah. Then you can see a structure which is going here. What is this? What I'm trying to draw now.
Quadrigemine system.
Now, what is this?
Midbrain.
This is your
collicle.
Third ventricle.
Third ventricle. Thalamus interthalamic adhesion. This is your interthalamic adhesion. This part, na? This is your interthalamic adhesion. Then you see third ventricle going like this. What is this? What is this? Which connects third ventricle, fourth ventricle? Aqueduct. Correct? Then which is connected to fourth ventricle. Correct?
Fourth ventricle. Yes.
So now you got an idea. Suppose in a premature baby, here also, if too much arachnoid space is there, that also can give you a feel of brain atrophy. If there is a certain value for your foramen magna, usually around 3 mm to 10 mm, 8 to 10 mm, less than that it will be there, but you don't have to remember the value. See the chart, median value of that particular space, and you can stick it and you can compare it. For each, whether you go with ventricular width, anterior ventricular width, thalamo-occipital distance, Levin's index, Davies scoring, for everything there's a chart. You need to chart that and you can follow that. If you keep on doing it, then you will remember it better. The values you'll remember it better. You don't have to remember and mug up the value. Keep the chart and see every time when you do it. So these are the structure. All right. So now this is a homogeneous brain parenchyma. You also got confused. Your first impression when you saw the image was it was a periventricular flare. Entire thing. One more thing was the entire image got lighted up because of the premature brain. That could indicate parenchymal edema. So can somebody tell me what are the reasons for brain edema? See, this topic is little dry. The only way we can make it interesting is mutually you have to speak. Even if you say wrong also, don't tell your name. We'll tell Kamal sir not to mark you. Kamal sir also will not mark you. Don't worry. Please tell. So what are the reasons for brain edema which you are aware of? Tell one or two. Sorry?
HIE.
HIE,
sir.
Very good. Very good. Very good.
Yes.
Infection.
Hypoglycemia.
Yes. So anything which leads to
Hypernatremia.
Exactly. I think enough. Exactly. Very good. So what you have to remember is when it comes to when you see overall picture of the ultrasound image, you need to think that this belongs to a premature baby or a mature baby. Lot of sulci gyri is there, not there. Overall, how does the image look? But you have to go systematic way. So you need to remember that extreme premature babies brain will have less sulci gyri. The only prominent thing which you see will be your Sylvian fissure. Even that will get separated in extreme premature babies. So the convolution and formation of sulci gyri starts getting better after 28 weeks. Up to 24 to 28 weeks, you can see parieto-occipital fissure, your calcarine fissure, cingulate sulci. And after 30 weeks, the maturation gets better and you start seeing more of sulci gyri, nothing but convolution of the brain. Now, this picture I have put, can anybody tell me, do you see it's a term baby, preterm baby you feel is less than 30 weeks, more than 30 weeks? What do you feel with the image? The first image I had put, correct? Yeah.
More than 30.
See, sorry? More than 30 weeks. Very good. Because you see.
Sir, gyri in sulci, sir.
You see your cingulate gyri also. Then you
Yes.
see your corpus callosum also you can see. What is this structure which you are seeing here? Below the corpus callosum?
That is
Kevam.
Kevam septum pellucidum.
Yeah. See, now you are in. You are syncing with me. So there is. You can see that you feel this with this image. You feel whether brain edema there not.
Mild edema is there, sir.
Okay. Why do you feel there is mild edema?
Because I am seeing a lot of flare, sir. In spite of sulci and gyri, I could see some flare also, sir. Okay,
all right. See, there is edema there present, not present. There is no called mild, moderate, and severe edema. Edema is edema only. All right. Edema is there. Yeah. So in this picture, so we have taken a coronal section, correct? So yes, you can see center structure. What is this? Same baby. What is this?
Yes. This third ventricle, sir.
So cavum septum pellucidum is placed on either side of cavum septum pellucidum. What you will get? Which cavity? Which part of the ventricular system you will get?
Anterior horn of lateral ventricle.
Anterior horn of lateral.
Are you seeing any anterior horn of the ventricle here?
No, sir.
Yeah. So it is basically compressed. Correct? You agree?
Yes, sir.
Yeah. But this baby we did as a follow-up scan. Baby is clinically fine and baby is taking feeds well. There is no issue. But when you do a scan, you feel there is an edema. That means every ultrasound image like ECG and rest of the things, clinical correlation is mandatory. So this baby is nothing but ventricular collapse, may be confused with your brain parenchymal edema causing ventricular collapse. So any form of edema, whether you take vasogenic edema, cytotoxic edema, whatever type of edema, if it is there, you see ventricular collapse. So if you don't see ventricles, you don't have to get worried. You have to clinically correlate, look at other angles and see the overall follow-up. You have to do the follow-up of the baby. But ventricular collapse, which is normally seen, can get can make you confused with edema causing compression. All right. So far you're clear. Now this is the image. So now any one of you can tell me, I've specifically marked. So which section of the coronal section we have taken image? Can anybody tell me? Is it in which part of the lateral ventricle we have taken this image?
Posterior horn of lateral ventricle.
Yes, trigone. Why do you say it is posterior horn? Because you see choroid plexus, correct? Yes. Yes, sir. See, whenever you take an image, it has to be interhemispheric fissure should be in the center. Then the second thing is the gain, the brightness of the structure from near up to the pro and to the far should be equal. So the image is a good quality image. So now you are seeing two ventricle system. Do you feel the ventricle shape of the ventricles is same or it is different?
Different, sir.
Different. So another variant which you need to remember is shape of the ventricles can be different. So the one with bigger ventricle can have more choroid plexus. So you don't have to get confused saying that, there is some bleed, nothing like that. Your shape of the ventricles can alter. It is not mandatory. So in the ultrasound rule, last time I told you, normal can be symmetrical, but not all normal should be symmetrical. So asymmetry can also be accepted as normal. So key feature, we take different ventricular measurement that I'll be telling you when I take up AVH and hydrocephalus class. So basic things which you need to remember is they can have variation in the size of ventricles. So you see prominent ventricles if it's an extreme premature baby, and there also right versus left can vary. So asymmetry of ventricle is normal, which is seen in around 20 to 40% of the infants. So most of the time you see left ventricle little larger than the right ventricle. And this is one of the few statistics, but you don't have to mug up all this. You need to remember that yes, we can have variation in the ventricular size. So we have a specific measurement of the ventricles. Take out that chart and start charting in that. You will know whether it is normal or abnormal. So asymmetry, these are the few things. Asymmetry of the frontal and occipital horn is common, should not be mistaken for a disease. Ventricular asymmetry is usually more pronounced in the posterior portion of the occipital horn. That is a picture which I had put over there. So left ventricle is often larger than the right ventricle. These are the few statistics. You remember this, that it is not mandatory to be symmetrical to call it as normal. So can anybody tell me, I have marked certain things in this picture. First of all, you tell me this is a term baby or a preterm baby. Anybody can tell. Yeah.
Preterm baby.
Preterm baby. Very good. Why do you feel it is preterm baby, which we have already discussed? All right. So this is what section have we taken, the first image and the second image? Parasagittal. Fantastic. So looking at the image, what do you feel? What do you feel? Why do you feel it is normal? What is this?
The caudothalamic notch is free.
Okay, so this part you are telling it is free. Very good. That's the first thing what you need to observe. Then what is this which you are seeing here?
Choroid plexus. That is a flare.
Flare. You are seeing a flare, correct? But do you see any difference in the flare from compared to choroid plexus? Do you feel the brightness is less or
Less.
Less.
okay?
Less.
So another key important thing is always the brightness should be compared with your choroid plexus brightness. Clear? So this we have taken another section, that is your trigone of lateral ventricular coronal section. So you have to compare the brightness. So prominent periventricular halo may be confused with your brain parenchymal hemorrhage or leukomalacia. So you have to compare with the choroid plexus. This is called pseudo lesion. So if you have doubt, sometimes when you place a probe, when you place the ultrasound probe, there is, because of the reflection, and if it is not placed at the perfect angle, see, usually when you're placing in the parasagittal section, the lateral ventricle anterior is more close to the interhemispheric fissure. Posteriorly, it goes little beyond. That means more towards lateral. So when you're placing a probe, it should be in that position only, so that you take a proper section. Suppose if you alter that, you feel that there is some periventricular leukomalacia or ecodensity or periventricular flare at just above the parietal to occipital region. So if you have doubt, go with your posterior fontanelle view. So in that, if you don't see any changes, that means you are convinced. As I said, if there is a flare, it should be there in all planes. So if that ecodensity is not there, then placing of a probe also can give you that picture. Then another thing, first thing is you have to compare the brightness with your choroid plexus. Second thing, you have to see in different both sagittal, coronal and posterior fontanelle if you feel any abnormality if it is there. So this also from prominent periventricular halo may be confused. Any physiological periventricular change, ecodensity, usually disappears by 7 days. That's why after 7 days, after a week, what you do, scan. that plays a crucial role in terms of explaining to the parents. But serial scan is very, very important. With one scan, you should never commit and say that your baby has got changes, your baby will have this, that. You explain the risk, but you cannot brand the baby with that just because you have started doing it. So this is what I was talking about. Less echo density than the neighboring choroid plexus, and it should always be seen in 2 planes. Clear? Can anybody tell me what is it? I have marked it. Do you feel there is an hemorrhage or there is no hemorrhage? We have 2 types of hemorrhage. What are the 2 types of hemorrhage in this picture? If you take, one is your germinal matrix bleed, choroid plexus bleed, or parenchymal bleed in bleeding disorders you get. So we will only stick to choroid plexus bleeding or germinal matrix bleeding. So can anybody tell me where does germinal matrix is present, where all it is present if it is less than 28 weeks and post 28 weeks? Germinal
After 20.
Periventricular area.
Caudothalamic groove.
Yeah, where? Okay, I'll just, okay, that you take care of it, you read it later. I'll just ask only one thing. So when you grade a bleed, what is grade 1 bleed?
Caudothalamic notch.
Caudothalamic notch. Because your ultimate germinal matrix, after being everywhere, comes and gets stuck in caudothalamic groove, and it disappears by around 36 to 37 weeks. That's why in premature baby, who are less than 34 weeks or who are less than 30 weeks in grade 1 bleed, we see first because that is the last one to disappear, the germinal matrix. So here the notch is free, correct? Then there is something called as choroid plexus. So where all choroid plexus is there? It's in the trigone of the lateral ventricle, correct? Yeah, so looking at this image, you feel there is a periventricular echo density. Sometimes what happens, this ventricle can imaginate into the convexity of the parenchyma, that can give you a feel of leukomalacia or periventricular flare. So try to do from posterior fontanelle and try to see. Sometimes it, even the calcarean fissure imaginate and can give you a feel of a bleed, or it can give you a feel of periventricular flare. So calcarean fissure is the one which separates your parietal to occipital cortex lobes. So if that imaginates into the posterior part of your lateral ventricle, that can give a feel of a bleed, and that can give you a feel of your periventricular flare. So that's why try to take from 2 different planes. Don't go by with one single image of periventricular flare. So in this, straight away you can see below the lateral ventricle is the point where you get your caudothalamic groove, because lateral ventricle, thalamus, caudate nucleus, and below caudate nucleus you get your thalamus, correct? We have seen in the 3-dimension picture. So in this picture, you feel there is a bleed or there is no bleed?
No
yes
bleed.
or no?
No bleed.
Why do you feel there is no bleed?
That is the choroid plexus, that is in the trigone, lateral ventricle trigone.
Okay. So coming to the second image. So sometimes excellent, yeah, called accurate. So prominence of choroid plexus, which is emerging, because usually choroid plexus can be there all throughout depending on the gestation baby. So that can give you a feel of grade 1 bleed. So if you have doubt, try to take the parasagittal section and see at the caudothalamic groove notch, you will get an idea, and try to compare the bleeding echo density with your choroid plexus echo density and try to see in different places. So as you rightly said, yes, but still this variation can confuse you. So you have to take caudothalamic groove. I was talking about this particular part, germinal matrix, where exactly it ends and finally convolutes is the caudothalamic groove. That's why first we see the bleed there, if it is there, based on whether it has leaked into the ventricular system, whether it is 50%, more than 50%, with dilatation, without dilatation, is how we classify the grades of bleed. So choroid plexus pathologies. So now we have seen a choroid plexus prominating. Suppose if there are situations where you can get choroid plexus 6 cyst also, small cyst. So that also can give you a feel of your bleed. So it is very important that you remember this variation. See now this image I have put, where one side I have put a Doppler, another side I have put the parasagittal section, and in the temporal horn or the inferior horn, and in the trigone you can see that there is some hypoechoic lesions here in the choroid plexus. So if there is choroid plexus cutouts, sometimes might get confused with your cystic lesion or your blood clot. So always remember whether it is single, what is the measurement, and whether it is multiple, larger than 1 mm, more than 1 centimeter, less than 1 centimeter, or you can always calculate in millimeters also. If there are multiple bilateral, then usually it's associated with chromosomal anomalies. We just see whether there is any split. How does it look? Sometimes a well-formed clot, which is sitting on the body of the ventricle, can give you a feel of choroid plexus. So you will have echoic, hyperechoic, and echoic. Like that, a layer of formation will be there. That also we'll discuss. I'll put a nice slide in the next class when I take up IVH and PVR. So you have to remember about the choroid plexus pathologies. So if you have a doubt about the blood clot versus the cyst, put a Doppler and see, you will get an idea about whether it is blood or no blood. So this is another image. I have marked it. Sometimes your choroid plexus can have lobulation. Choroid plexus can have prominence, cystic lesion, lobulation. All these things get confused with your blood clot. If you have a doubt, please put a Doppler and try to see. So you can see clearly. Can you see a cyst here?
Yes.
So this can get confused if baby is sick and baby has an issue with single thing, So in the interesting part about the cyst, there is something called as conotal area. You have few which are appearing here, few cysts which are appearing here, and few cysts which are appearing here. Conotal place, subependymal place, adjacent to the lateral ventricle and above the lateral ventricle. Based on that also, whether it is pathological or non-pathological or physiological, we can subependymal usually, you get cysts, or it's because of a sequela of germinal matrix. That's a point where your caudothalamic grew. So germinal-atic lesions are usually associated with your metabolic disorder. So this is what I was talking about: subependymal cyst, conotal cyst, lateral to that, and here. So this also I will show you the class, but you remember that cyst can appear in different position, which can confuse you with infection or with your pathological, or the stage 3 to 4 periventricular leukomalacia with cyst formation. So this is what which I was talking about the position of the cyst. Now here I have marked something. What is that in both the picture? In red color arrow, what is it? Cisterna magna. See, what is this? What you are seeing here?
Cerebellum.
No, below that cerebellum is there. What is this? Tentorium?
Tentorium cerebellum.
Like, suppose if it gets elevated like this, and then you see more gap here, and you don't see any vermis. You see truncated vermis with the posterior fossa space is increasing. What do you suspect?
Dandy Walker malformation.
Excellent.
Dandy Walker malformation.
Yes. So I have a few slides also where you might get confused. That I'll come later. So when you see cisterna magna, always try to measure the length of the cisterna magna, both in mid-sagittal section and even in coronal section, and try to chart it with the chart. Don't get confused. Sometimes you might get confused with your, there is something called as Blake's cyst. That's all extreme thing. We don't have to talk about it now, where the fourth ventricle can have a cyst persisting like a hat. Anyway, so in cisterna magna, you might get confused based on cerebellar hypoplasia if you feel a gap. But if you feel that way, try to measure the cisterna magna and try to understand whether it is within comes in normal limit, and try to look at other things like tentorium, whether it is elevated or not. Are you seeing any vermis or not? Whether you are seeing any bleed in the cerebellar hemisphere, whether you see a symmetry with cerebellum. So these are the things which you need to look into that. So cisterna magna usually, as I said, 8 to 10 mm in both sagittal and axial planes. So mega cisterna magna might be present in 1% of your brain images as well, but try to see whether other things as well in the posterior fossa. So when we see variation, you can have variation in posterior fossa of the brain and the anterior fossa of the brain as well. So one thing which always we should not miss is your the common things which you see in posterior fossa abnormality, that is your Dandy Walker malformation. So I've already told you the triad. So this image is from anterior fontanelle or posterior fontanelle?
Posterior one.
Why do you say it is posterior fontanelle? Because your occipital horn is erected. Seeing through this, if you take I don't have one second. If I have any image, you'll get to know. Yeah. See here, posterior now. It is down. This is your anterior fontanelle you have taken. Clear? So your occipital horn is erected means that is your posterior fontanelle. Through posterior fontanelle, you have taken the picture. Correct? I was talking about the calcarine fissure, trying to invaginate into the posterior part of the lateral ventricle, which can give you, echogenic sulci in the ventricles. So if you have a doubt, put a color Doppler and try to see whether you're getting confused with the bleed or not. This already I've already spoken. So in this picture, what is the thing which I have marked? So you read from top to bottom. Can you see the picture? What is the thing which I have marked? What is it?
Interhemispheric fissure.
First image. This is what, whether it is from anterior fontanelle we have taken, correct? Whether it is mid-sagittal or parasagittal, or in between mid and parasagittal.
Parasagittal.
Correct. So what is this? You are seeing something now here.
Central.
Subarachnoid space. Your meningeal covering space is there. You agree? See the gap. So I've taken in coronal section also. You can see the gap here.
Yes.
See, even interhemispheric fissure, there is widening is there. You agree?
Yes. Yes.
Yes, sir.
So you get a feel when you do an image that there could be a brain atrophy. There could be a volume loss of the brain. Sometimes even with space, if clinically fine, if there is no antenatal incident, natal incident, or postnatally any no neonatal thing, maybe otherwise fine, you might find this abnormal normal variation in the brain as well. It's more closer to, if you have your autistic probe, you can see, you can and try to focus on the proximal part and try to see the your subarachnoid space measurement. So this is what I was talking about. So a normal range can be between 0 to 3.3 or even 1.6. So if it is crossing beyond that, then you need to think abnormal. So try to plot it with the chart. So this is the thing which I wanted you to remember. Suppose if you have more than 6 mm subarachnoid space, and there was history of infection, meningeal infection, or there was history of a rough initial first 2 days of a rough course, NICU course for a baby, what is the thing which you think of? This is an alarming thing. So the beauty of ultrasound is you can, what I'm talking about, can anybody tell me? There is increase in ventricular size, there is increase in subarachnoid space, there was history of bleed.
Intraventricular
What?
hemorrhage.
Sorry?
Intraventricular, intracerebral hemorrhage, sir.
Yeah, hemorrhage, but leading to what complication? The early sign of your hydrocephalus.
Hydrocephalus, sir.
Yes, with ultrasound, even before you could see the enlargement of the brain the circumference, you will be able to predict based on the chart, based on the scoring, whether hydrocephalus will happen or not. Plus, with your ultrasound, you'll be able to tell whether this particular measurement needs intervention or not. So that also I'll be talking in the next class. So ultrasound in that way will give you a heads up, or where you can actually it's like a time machine. You can predict certain many things with your ultrasound findings. All right. So what do you see here?
K1. The third ventricle. Third ventricle.
No, it's cavum septum pellucidum only, but it might get confused with your cystic lesion sometimes. So cavum septum pellucidum, cavum virgi, and cavum valle interposita. These are the three things. If you see below the corpus callosum, genu and the body, that is your thing. If it is posterior to the fornix, you have seen the fornix, no? First comes your thalamus, two thalamus. In between fornix comes. Then you have your corpus callosum. In between, you get your cavum septum pellucidum. If it is posterior to the thalamus or posterior to your fornix, that is termed as cavum virgi. And if it is in the pineal region, pineal gland I have shown you, no? Pineal region, that will as interpositum, that comes as a posterior thing. So even cavum septum pellucidum usually might persist up to 6 months of age, and it can be there not only pellucidum, virgi and interpositum also can be there. So you should be careful about the position. Suppose if you have a doubt about some vascular malformation or some bleed which is resolving like that, if you feel, you put a Doppler and see. If there is no color in that, you don't have to worry. So as I said, most of the fetal fluid filled spaces will beginning at 6 months, but it might persist up to 6 months also. These are the few things which I have written. These are the few other images which I was talking about. Cavum septum pellucidum, then your cavum virgi, which can be posterior to the fornix, and interpositum you can see here. Can you see this? This is your interpositum. Posterior to the fornix. These are the few images. Can you see choroidal cyst here? Can you see here cystic lesion, which I'm marking now? See here?
Yes.
Yeah, this could also be single, multiple, bilateral, usually single, unilateral. You don't have to worry. If it's multiple, then you have to think of chromosomal anomalies could be there, but you have to look at other antenatal history as well. So these are the few things which other mineralizing vasculopathy, lenticular striate vessels can have mineralization that can give you calcifying brain lesions. These are the few pictures. Pseudocyst already we have told you. One is the conatal area, then you have germanolytic cyst, then you have periventricular leukomalacia, and you have arterial cyst, venous arterial, because of the arterial infarct you might get, or venous infarction you get. That two things I will take next class. So this is what I was talking about. See here, 1, 2. That is your germanolytic cyst and pseudocyst. 3 is your cystic periventricular leukomalacia. And what you see fourth one, can anybody tell me? What is this?
Conatal cyst.
what is that? It's a venous infarct because your terminal vein gets compressed here, and that causes, because of the bleed, which I'll show you in the next class, the terminal vein gets compressed. Because of terminal supply is blocked, you get your periventricular venous, post venous hemorrhagic infarction that you typically see in this fourth location. Pseudocyst also can be there. You have to try to check in two different planes. Germanolytic cyst, I've already told you, it's in cordothalamic group. Single unilateral, what exactly it is. Associated other things also you have to see. Limitation, there are limitation every thing. So if there are, these are the few things which are limitation, which I don't think it is important at this point of time. But if you have any doubt, any of the brain MRI is always to be done in case of an extreme premature baby where you are trying to counsel the thing or predict. Maybe after a month or 6 weeks of life, you can go with that. Thank you. I've tried my best to make this topic very interesting. Don't worry, all these slides we'll be sharing also, and video also we'll bring. In coming next class, I'll be taking on PVL, IVH, hydrocephalus measurements, and I will try to show the pictures as well, and try to give you a pitfalls about each and every grade 1, grade 2, grade 3 about PVL, where you can get confused about grading system, how to remember the grading system, how to interpret leads. Everything I'll be telling you in the next coming class. That is it. That is on Tuesday. All right, Dinakar sir, would you like to add anything, sir?
Thank you, sir.
Thank you, ma. Dinakar sir, you are there?
Prashant?
Yes, sir. Yes, sir. Please add if anything is there. I'm asking my guru. Sir, please add, sir.
All the things are very good. Excellent explanation. I am just watching all the slides. Very good teaching. People have understood. Now, please go ahead and try to do the, hands-on training.
That's what. I have only 1 or 2 babies now, sir. But I'll promise them to do hands-on training in next class, sir. Because all are born from feet, and few of them have got infection also. That's why I'm not entering there. So my humble request is, if you have, you can show, sir, from your side if you have. I'm very sorry today.
Let them stay there. Okay, I'll ask one question.
Sir.
I ask one question to all the people.
Yes, sir. Yes, sir.
Dear participants, I am testing Dr. Prashant Gowda's teaching today. Don't feel otherwise. Okay. So tell me, which ventricle will be bigger?
Left ventricle.
Left ventricle.
Left ventricle. Okay.
Left ventricle.
Okay. You told left ventricle. So which choroid plexus will be bigger?
Left.
No, sir. Choroid plexus. See, one thing how to remember is, this is the only one thing to remember. Left eyes will be slightly bigger than the right.
Why?
Okay, left facial things morphologically slightly bigger than the right, slightly bigger. So left breast will be bigger. Left testis is very down. Left testis is bigger. Okay, left kidney is slightly bigger.
And even the left foot.
Okay, everything left. Because that is the reason man will give always to the left, bigger. Wife also left. That is the way we should respect. Okay. Only one thing is, choroid plexus lobulated and bigger will be, choroid plexus lobulated is right side. So remember that, number 1. Choroid plexus right side is lobulated and bigger. Okay. Number 1. Suppose, so second question, Prashant, this is for your teaching test. Second, now 28-weeker baby, What is the signature? Just I am asking you. Can anybody tell me what is the signature of the brine? How brine should appear? Signature of the brine. This is all the points lifelong you should not forget. Before I show the hands-on training.
Right occipital fissure would be present.
Poorly formed Salsa and Gary.
What is the signature of the brine in ultrasound?
Salsa and Gary are not
Hemorrhage in the
well-formed.
chorothalamic groove.
Sir, signature means it is a normal. Why hemorrhage will come? Sulci gyrus, somebody is telling, but can you able to tell me little more better?
Right occipital.
Not clearly formed, sir. Salsa and Gary are not clearly.
No, dear friend, it is not that. No.
Cingulate gyrus.
Hyper.
Right occipital sulcus and singular gyrus.
Sir?
Not well. Singlet. Not.
Signature means normal appearance. Signature means not after 8 o'clock we use something. That is, signature is different. That is different. Okay. Number one is always how the brain looks in ultrasound 2D image, white, black, white, black. Yes or no?
White.
Everything is gray image. See, somebody was telling sulci and somebody was telling fissure. Which one will appear bright?
Fisher.
Okay. Why fissure will appear? Gyrus is appears. What is gyrus contains? What is fissure?
Gray matter.
Gray matter.
Gary gray matter, sir.
Fissure diameter.
Gray matter. Are you sure there is no white matter? Because this is the
sir.
basics you people should know to tell the brain edema. Because if you don't know the signature, whatever you read, it is only a that time memory. That means you are not into the depth of the ultrasound, not depth. It is the basics thing that we are going to show you today. Number one. Then 34-weeker baby has come to you, 28-weeker, 26-weeker baby has come to you people. Now, how thalamus should appear? 26-weeker baby, how thalamus should appear normally in ultrasound?
White.
White.
Sir?
White.
Right.
White.
White.
Why not? Oh, why not black? Why not gray? Why white?
White matter, sir. Hyper intensity.
Why? White under hyper intensity. Why?
White matter. Thalamus.
Because.
Yeah. So, sir, one thing, whoever told white matter, sir, it is white. Sir, thalamus is completely made up of white, gray matter, sir. Somebody who is talking there, it's completely made up of basal ganglia is made up of white matter, sorry, gray matter. Gray matter always to be appears as a gray, not white. Somebody who is saying it is wrong answer, please don't carry the image. That's what today class Prashant Gowda has taken. Okay, that also we are going to tell you today. Today we are going to tell you. Okay, once that signature you will come to know, then I am going to tell you in extreme premature baby how it appears. Then what is the normal variant is the class. If you don't know the normal variants, so you will think that is pathology, and you will label it as an pathology. But baby will be walking after 2 years in front of you, jumping, hopping, everything. Then you will think what I did. Then in the meantime, you will confuse all the people. You will give blood pressure to all your colleagues. If you don't know the normal variant. Okay. Number second. One more thing. Why I am making you to stay with me for the hands-on training program? That is the reason I am asking you. Okay. How many people have seen cerebellum? Everybody has seen cerebellum. Suppose if the cleft is there in the cerebellum, is it normal or abnormal? If complete cerebellar cleft is there, what is the diagnosis? If cleft is there, minimal cleft is there. Because I don't want to use something language, but we are doctors. Because if I'll talk something to make you people remember, I can use some word, but I don't want to use, because if it is something close contact, males are there, I would have used it. I cannot use here because make you remember. Otherwise, you know, sometimes good words might not stick, good unparliamentary words will stick into the brain. I'm asking you one thing. If cerebellum is clefted, what is the diagnosis? But partially cleft, is it normal or abnormal? It's a normal variant or abnormal variant?
Complete cleft, Dandy Walker.
Very good. I'm happy.
Partial cleft could be normal.
Okay, you are telling Dandy Walker. Okay, is it Dandy Walker type 1, type 2 or something else? Something else.
Arnold Carey.
I am happy. Dandy Chari is the correct answer. Even Arnold Chari, partial cleft will come. But partial cleft in a premature baby, okay, small cleft where like a clitoris, it will hold the both the what is that? Just imagine the clitoris in a premature baby. It will be like a hypertrophied because majora is not covering the vagina. Like that, in a premature baby, wormies will become a little hypertrophied picture you will get, where you will get a cerebellum apart. So you will think it is an cleft, but it is not. It is not. Okay, but that is the reason even small things you should not miss. One more thing. Suppose if you are seeing in coronal section, if you are seeing in the coronal section somewhere hyperechogenicity, do you label it as an infarction or not?
No, sir. We'll check in the other section also.
Very good. I am very happy. I will check in other section to comment. Very good answer. So correct answer what she told. Then one more thing I am going to ask you people. Now why I am asking you all these things are to don't jump, because in excitement we should not do some mistakes. So too much excitement. And one more thing, why we will get in a premature baby thalamus and all, because there is water, more water content will be there in the premature baby. Water content will be very high in the developing brain. That interference means in between the tissue and that water, it will appear bright. So you should not think, oh, cardothalamic groove become white, so there is asphyxia, there is a problem. Never label it. As the child grows, water content will reduce. Baby will have more astrocyte than neuroglial cells. So all the other thing, then it will become normal gray matter. Number one. The second thing, now you people are seeing in a preterm baby, late preterm baby, and term baby, near the not cardothalamic group. Almost it is a late preterm baby and term baby. You are seeing the germinal matrix is hyperechogenic. Completely germinal matrix is hyperechogenic. What is your impression?
Sir, in preterm it is normal.
How many times you have seen preterm baby complete germinal matrix or hyperechogenic?
Not germinal matrix is not well formed.
Hey, preterm baby well formed kadama.
Sir, so it is high.
It is well formed. Well formed means what? It is fully there.
It will be high.
34 weaker, it won't be available. Okay.
Yes.
So what is the reason where you will find complete germinal matrix just below the lateral ventricle in the sagittal region? If you are seeing, what is your impression? So I will give you one more clue. IUGR baby, preterm baby, mother had repeated bleeding and hypoxia, multiple times admitted. Baby is SGA or IUGR. Now I am going to give you the things. If it is antiphospholipids, probably positive, or you might not know. Okay, now you tell me. Wait. Tell me.
Antenatal bleed.
Sir,
Antenatal.
Bleed.
Sir.
antenatal.
Please, whenever you see germinal matrix is just below the sagittal, in the sagittal angle, if you are seeing the lateral ventricle, anterior horn, you are seeing body, you are seeing, okay, till the caudothalamic groove, you can mark it out. The germinal matrix is hyperechogenic. That is the reason intrauterine germinal matrix infarction you should rule out.
Okay.
Means it has occurred long time back. You understood? Long time back, it has infarction is occurred. Slowly, what happens? That baby will start developing hydrocephalus ex vacuum because that portion is eaten up later. So without hydrocephalus ex vacuum will develop. That portion, whatever it contains, it is more dangerous. So why I am telling, whenever you see the germinal matrix compared to the normal, it is more hyperechogenic. Please ask the history, you will find it. Don't give normal brain scanning to be followed up every week. Because of this reason, hyperechogenic to be followed up. Okay, because it is not a very deep or it is going above our heads. It is wrong. It is all simple because you people are DMs, fellows. It is, if anybody tells me, sir, it is above our head going, sir, then you are not fit for any fellowship or anything because you are past DCH or MD. Whatever I am telling, at least you should catch. Because why I am using this word is, I came to know through the people, sir, it is going above head. Yeah, you are finishing MD, DCHR. It is easy. Just before uttering that word, dear friends, we will try to learn. Even I have learned over 29 years. Not one day. No. We will also learn slowly. Okay, now I am going on one more thing. Simple basics I am going to ask you people. See, why I am talking like this is, whatever the suffer I have gone through in my life, I don't want you people to suffer. I want you people, that is the reason I am planning to give the spoon feeding. Please learn, save the babies. Save the babies. Somewhere God will help us because we are all doctors saving the babies. Don't give blood pressure to the parents. Number one. Number two. Now I will ask you one thing. Now you see in the coronal section of the normal brain. Coronal section of the normal brain. What is the first view named as?
Frontal horn.
Lateral horns of anterior horns. Lateral ventricles will be, sir.
Wrong, madam.
Coronal, sir.
Frontal lobe.
Coronal section first view.
Coronal.
Frontal lobe.
Sir?
From skin to
Frontal
sir.
lobe.
Sir, correct. Somebody told correct answer. Frontal lobes. I am very happy, sir. I am very happy. Somebody answered me. I am very happy, sir. Really happy, sir. Sir, why that image? How it will help you, sir? Why you are doing that, sir, before I show?
we can see if there is any fracture in the orbits in case of
Correct,
term
sir.
babies.
Correct, sir. Lens dislocation
Then
in the orbit.
usually there will be some amount of hyperechogenicity in preterm babies.
It will be the normal. Still, you
Normal
are seeing. What is the reason, sir? Sir, why that frontal lobe will have hyperecogeny? You are telling me, sir. Even if you see in a term baby, it will appear more hyperecogenic compared to the as you come inside. Why, sir? Then what is the use of that angling?
That is
Madam Ji.
so same increased fluid.
No. That's what today I am going to tell you people. If you are bearing my 10 minutes or 30 minutes torture, don't feel bad, because I want when Kamal and our person, okay, Vaideshwaran, when he asked us, then I told guarantee we will give you, your PGs will 100% learn and go. I don't want to listen everything was going above our brain. Please. To tell you very frankly, I am not talking because I am not able to get up and even talk. Really, I am having severe, not corona, severe viral fever with severe myalgia, not able to even talk. Still, I am getting up in my face. I want to teach. I have given the words to my people. I will teach. That is the reason I am requesting our this person. Still, but if you are not showing interest, my all persistence will go off, because I don't get success. You know, success means hard work plus persistence is equal to success. So please, for my persistence, I need your cooperation too. Okay, number second, angle, coronal view. What is that?
Anterior horn of lateral ventricle.
Yes, sir. Correct, sir. Sir, what kind of things you are going to see in that? That angling is important, sir.
Corpus callosum.
Sir,
Cavum
sir,
septum
are you
pelvis.
going to see the corpus callosum, sir? Sir, once again, somebody is telling corpus callosum. Sir, please, because you are answering very good, sir. Alochane madi. Alochane means think and tell me.
Below the interhemispheric fissure, we can see the corpus callosum.
Are you able to see anterior horn? Near the anterior horn of the lateral ventricle, are you able to see the corpus callosum?
Splenium.
The interhemispheric fissure, below that is the
Okay.
corpus callosum. Below that is the cavum septum pelvis.
Still corpus callosum you are telling. Imagine the brain. Prashant was opening up his lungs, sir. Okay. Later.
Cavum septum pelvis.
Cavum pellucidum.
Okay, sir.
And third
Lateral to that is the anterior horn of lateral ventricle.
Okay, I will show you, then I'll come back to you. Whoever answering, I'll come back to you. Then you have to correct yourself. Okay, what is third view? I didn't ask you what is the significance. You didn't answer me. What is the third view, sir?
Foramen of Monro view.
Sir, very good, sir. Foramen, third ventricle, sir. Third ventricle. I am happy, sir. Sir, please write it down right now. Write down. Please write down. Make life easier. First view, frontal view. Second view, anterior horns. Third view, third ventricle.
fourth.
Third ventricle. Third ventricle. Sir, what and all things you are going to see why this angling is important, sir? Third view.
for calculating the ventricular index.
Very good, sir. I am very happy. Not only ventricular index, all the ventricular measurements, this is the best. This is the correct answer you are supposed to tell me. Not only ventricular index, for all the ventricular measurements, this is better. Okay, very good. I am talking about coronal. That is the reason I am using. Anything else? You are correct. You are correct. 100% correct. Next. What else you can see in this? Why this angling is better? Sir, tell me. Below the third ventricle, what is there? Just imagine the anatomy. Sagittal anatomy, imagine. Okay. So thalamus is there. So thalamus is there. Next to the ventricle, there is a thalamus. Next to the thalamus, you are going to see the internal capsule. Then next to the internal capsule, you are going to see the, what is that? Globus pallidus. Then next to the globus pallidus, you are going to putamen. After that, you are going to see the internal cap. What is it? External capsule. Then synovian fissure. Sorry, internal capsule, globus putamen, then synovian fissure. Why this angling is important? This is called in MRI when you are reading theory, MRI findings of birth asphyxia. That is called PLIC. What is PLC? Please, anybody? What is the MRI picture? How you will read the MRI in the birth asphyxia? 3 points. Posterior limb of internal capsule. That's called PLIC. PLIC. Usually what happens? We should not see PLIC line usually. So because of the thalamus, globus pallidus will become hyperexogenic. PLIC will appear more black. That should not be normal find. That is not a normal finding in birth asphyxia. Not only that, you can see something called deep brain. So this is the deep brain problems. Why I am telling all the angles. Next, I think so. I will request Prashant to talk about what is the importance of that angling. Otherwise, you miss the bus. Next, what is the fourth line, sir? Fourth line. Fourth line. Fourth view. After the third ventricle.
Unmute and tell, unmute yourself.
Body of lateral ventricle, sir.
No. What is the fourth view? Easy. We told frontal horn. Then, sorry, first we told frontal lobe. Second, we told frontal horn. Third, we told third ventricle. This is the fourth one. Fourth. Yes, madam. No. Fourth one is a fourth ventricle. Fourth one is a fourth ventricle. Why that angle is important? In that fourth ventricle view, you are going to see very clear fourth ventricular view. You are going to see the cerebellum. You are going to see the cisterna magna. And you are going to see, okay, cisterna magna partial. Fourth ventricle, you are going to see properly. Okay, that is very, very important view for 2 reasons. Why that is the very important? Because of the forceps delivery, where hemorrhage can come to the posterior quadrigerminal cisterna. Means where cerebellum is there, above cerebrum is there, where fox is there. Fox means that meningeal covers. See, tent means it is horizontal. Fox means it is vertical. Remember, so fox cerebri, so where it will differ, that is the portion where you can see the hemorrhage. So simply there is, nobody kept it. So which is the fifth angle? Anybody?
Trigon.
Very nice. So I am going to put what you are telling is correct. Okay, I am going to slightly extend one more. What you told is correct, dear friend. But I am going to tell you cerebellum. I am going to put one more angle, one more line after the fourth ventricle, cerebellum. That is the angle I am going to tell you dancing doll. Dancing doll. I'll show you what is that meaning. Okay, why that angling is very important?
To look for any
Cerebellum,
creep in the
I'm
occipital.
putting into the cerebellum. Anybody? From the above you think cerebellum से ऊपर क्या है? What is there on the top?
Tentorium, posterior, tentorium cerebellum.
Tentorium के ऊपर, just above the tentorium, 45 minor.
Occipital.
Yeah, then
Occipital.
above that, you will find all the forks and everything. Wherever the hemorrhage occult is hidden, you can see as well as cerebellum. Why? Both the cerebellums we can see equally. Once we are seeing equally, anywhere equally that dancing doll gown should be equal. If that dancing doll, whatever the cerebellum, hypoechoic somewhere you are seeing, that means it is an hemorrhage. Because choroid plexus IVH not only will develop in intraventricular for lateral ventricle, can develop hemorrhage in third ventricle, fourth ventricle, because choroid plexus can sit even in the third ventricle, fourth ventricle also, just above the cerebellum. That is the important. I will show you that. Next is, somebody was telling, trigone, occipital horn. Why that angling is important? Why that angling is important?
To look for any bleed.
Yes, sir.
To look in the
So
periventricular
why
area,
where, sir, bleed?
the choroid plexus.
Yes. If it is not there in the choroid plexus,
Intraparent.
intra. Okay, madam. Next, dear friends, try to remember. Even sometimes, if you are suspecting strong hemorrhage, if you are not able to see the hemorrhage in the cardothalamic groove, if you are seeing something suspicion in the choroid plexus, but in that angle, if you are not seeing, this angle will give you posterior horn very clearly. Just detaching to the choroid plexus, even small hemorrhage is floating hyperechogenic in the posterior horn of the lateral ventricle. Okay, that is also a hemorrhage. You should not, never you should see any hyperechogenicity in the trigone or occipital horn, temporal horn, or the trigone, that junction. You should not see at all. That there it will help you. At this time, this is going to come, you are going to compare the choroid plexus to the parieto-occipital region flaring. This is the angle is very important. PVL will start from maximum here. This area and cerebellum area, you can just angling and put it. The last one is occipital horn. Okay, because occipital horn, you can find something called hemorrhage. So I will ask you one last question. Our Prashant today taught you people how you are going to differentiate between subarachnoid place, subdural place. In ultrasound, how you are going to differentiate subarachnoid space, subdural space. Prashant has put you people into the color things. Because you are supposed to diagnose. Suppose if there is a meningitis, usually subdural or subarachnoid hemorrhage, or if subarachnoid place is there in communicating hydrocephalus, how you are going to know? If there is a subdural something effusion, how you're going to know it is this? In ultrasound, how you're going
This
to yeah.
Sir is asking, how does the Tura matter look? How does the Pia matter look? And how does the the sequence is what he's asking. Correct, no, sir?
Sir.
How
Space,
Pia matter,
how you're
whether
going to
it's
diagnose this is the space.
non-echogenic. Pia matter, is it echogenic, non-echogenic? Dura matter, echogenic, non-echogenic?
Durameter is echogenic.
Prashant,
Yes, sir.
all the matters are echogenic, dear friend. All the matters are echogenic because all the matters, that is the reason wherever you see the sulcus, okay, sulcus and gyri. Gyri is a above, sulci is a depression. In the depression, there is meningeal, 3 layers of meninges is folded. All the meninges is made up of fat. Because of the property of the fat in the ultrasound is hyperechogenic, reflect the waves. That is the reason where we will see that meninges is appears as white. You understood now? Matter also white, arachnoid matter also white, dura matter also white. Number 1. So once white is coming, gray matter appears as in gray. Once again, white matter will be there. That is appears as in white. So sulci is what? White. The meningeal folds.
White.
Next is gray matter. Next is white matter. White, black, white. That is called brine signature. I was telling you people. So that is, I will show you how to. I think so. Prashant is going to teach you next class how to diagnose brine edema before somebody will diagnose. Prashant is going to teach you in the next class because that is the things. No more extra blah 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 blah. If anybody is telling blah blah, all are blah blah, all are waste. Okay, he's going to teach you people. Okay, number 1, how to diagnose subdural, and this thing is where the blood vessels will be there. Blood vessels will be there in the where CSF flows, dear friends. Sir, arachnoid space where CSF flows. Correct, sir. You are telling correct, sir. You are correct, sir. That is the place where blood vessels will be floating. So just above that, dura mater is there. Subdura is no blood vessels. That is the way you are going to put the Doppler steady or low continuous pulse repetition. You are going to reduce it because all are low flow blood. You are going to diagnose this is a dura mater. This is a arachnoid mater. That is because that's how you are going to diagnose in the meningitis. Okay, we will show you. It is not a big. Once again, please, dear friends, I request you because I am your brother. I want you people. Nobody to tell. Everybody is going above my head. We will teach you. Try 2-3 days. And there is a proverb in Kannada. I don't know whether it is there in the language. Till you learn, it is Brahma Vidya. Once you learn everything, it is a monkey Vidya. Okay? Ultrasound is also same thing, dear friends. I will take 10 minutes to show you all the views. Then next class, I'll show you the things. Come, babies. Okay, I am doing my hand washing. I did my hand washing. I am cleaning the probe. I know that you people wants to go for a practice. I'll take only 10 minutes. Sorry, not last time. I took till 5:30. I know everybody wants to run. So my thing is neonatal head, and this is the probe I am using. I'll show you first the images. So I am first in my left hand. I am searching for the AF. I got the AF. So I am trying. Whichever the things you are comfortable, dear friends, you can go ahead and do it. First thing, sagittal. Everybody knows it. Okay. And I am see how I am holding. My hand is touching the skull, such that I know feeling. So now I am putting in the, see this angling is in the anterior towards the, yeah. So you know this. This is the first view you are supposed to get. Everybody knows this. Cerebellum, fourth ventricle. See why I am telling one angle. This is a one angle where you are going to put in the coronal view. One angle here, one angle in the fourth, one angle in the third ventricle, another angle in the fourth ventricle, another one is cerebellum, another one is a posterior horn, another one is cerebellum. So 1, 2, 3, 4, 5, 6. So why I am telling you people is you don't miss 90%. Suppose if you are putting the third ventricle, you're going to cover the brain stem. Brains. This is what is that? Midbrain. This is brain stem. What is the brain stem? Pons is there, medulla is there, spinal cord is there. You are going to cover everything. If there is a hemorrhage, either here or hemorrhage here, we can see it. And anybody can tell me what is this? Anybody can tell me what is this? This is third ventricle. Everybody knows it. Clear? Yeah, this is third ventricle. Everybody knows this is third ventricle. Then what is this hyperechogeny? Anybody can tell me? Please, you have to answer. Otherwise, alone shouting is not good. What is this hyperechogenicity?
Quadrigeminal.
No. Make life simple.
Interthalamic connection.
Don't use big words. What is this hyperechogenicity? See, from here it goes and it is coming like this. And it is deep into the, somebody is telling correct. Sir, congratulations. Congratulations to you, sir. See why I am telling, please see this. This is called a lady in the gown because it is dipping into the third ventricle. See, it is dipping into the third ventricle. This is called a choroid plexus. Why I am telling, please go to the anatomy, see the internet, see the images. You are going to know what it is. This is the first question. So this one, inside this white and white, inside one is this black one is very important. That is called corpus callosum, not white one. So sometimes what happens here, it might be absent, then here it might be present. That is called partial. Suppose if it is absent, what happens is whatever you are seeing here, whitish, no, whitish. Can you see here the sulci gyrus? This one will come from this choroid plexus. That is called, from here it is sunburst. Sunburst means it will appear from here. White, like Surya and lines. Sunburst appearance. That is called sunburst appearance. Since corpus callosum is full here, I am relieved. Okay, this is the first sagittal. And here, what I am want to see, if it is a forceps, I want to know whether hemorrhage is there here or not. Whether hemorrhage is there here or not. Whether hemorrhage is posterior quadrigermina or anything here hemorrhage. And if there is a forceps here, you can see the break. Okay, this is the one. In the why I am telling you people to see is sometimes fracture of this rib. Cell. So now I am going to show you the back. So this is a proper, you can see lady in gown now. Okay, now I am going slightly one more angling. And one more thing, dear friends, I want you people to learn how to put the probe is also important. Come here. See, when I am putting the probe like this, when I am putting the probe like this, see what I am getting. 1 second. Can you show that? I am able to see the choroid plexus. But do you think I am happy here, friends? No. See, I want complete. How to get it? How to get that complete one? Come here. See, just like this, I am turning like this. See? Okay, oh, that's it.
Sir, image not visible, sir.
Prashanta, idana off maadu, video off maadu. Prashant, video off maadu. See now, this is the center, everybody knows. I am turning this thing. So not able to access complete. Number one. Number second thing, you are not able to see lateral ventricles also complete. So that is not the way to see. Okay, you are not, come here. Come here. Come here. Ilama, light back 1 second. Okay, switch on that light. Light is see, I am turning the probe slightly and going back. Yeah, see here, previously it was straight. See, this angle was straight. Now I am turning like this and showing the, okay, can you show there? See, you can see now, almost you can see. This is in the center. I'm going, yeah. What you should do is posterior side. Once again, this is anterior side. This posterior side, I have rotated like this because the thing is, okay, this is not straight. It is like this. It is like this. You have to, if you don't get anything, angulate. Then only you will get complete lateral ventricle with the choroid plexus. Turning. This one, the posterior one side, this one we should come to the this side. You will come to know if you will do this. Okay, this is one catch point of teaching. Next. Okay, now show them. Okay, now I am going backside. See, now I can see the posterior horn very clearly. I can see the even choroid plexus complete. I can see the complete where it is there. I'm going slightly. Okay. Even occipital horn also I can see. Then see something. Please, dear friends, whenever you see this, this is the place. See, this is a even hole, small holes are there. But it is called a PVL. Prashant is going to take a class. It is PVL 1. Up to 1 week it will be there, later it disappears. Nothing to worry. And the second thing is, see, here not much lobulated or anything, everything is normal. This is also normal. And one more thing is, anything, see, what is this portion? Synovial fissure. Why it is very important? Suppose synovial fissure is important, middle cerebral artery obstruction or blockage, you will find all this portion is very, very, very white. What is this? 1, 2, 3, 4. All these things are bones. What is this bones? Once again, maxillary bone, jaw bone, and the skull bones. All those things. Now you have learned about. See now, where is the sulcus and gyrus? Anybody can tell me maximum? It is in the posterior. Remember, always sulcus and gyrus. And you people were asking what is the gut signature, right? See, I'm going to show you what you mean by gut signature. Sorry, not gut, brain signature. And Prashant will teach you people what is even gut signature too. When NEC we are taking. I will show you, I will take the other probe for teaching the linear probe, even that is enough to teach you what is meaning of brain. Because linear probe, I am taking the linear probe. This is once again anterior. I am trying to put it anterior. Okay, can you show this? See the beauty how we are getting. I'll show you almost I am near to. Yes, I think so. Nobody can teach you better than this. I'll freeze it. See, wherever I am showing, this is the one, all the things you can see where bright is attaching to the bright. I told you this is called sulci. There are all the layers are there of the meninges. So from here to here, it is a gyrus. So you people can see all are white matter. And one more thing, next to this one, what you can see the gray matter. This all this much till here to here, it is a meninges. Next brain starts. This is gyrus. The first one is black, one is gray matter. Gray matter is always black. Then come to the white matter. See, that's called white, black, white. Suppose if this gray matter will become white, gray matter will become white. Why it will become white? Because from here it starts becoming white, 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 because all the white matter brain edema will increase. Then this will get compression. That is the place where from here to here the length will increase. Now I will show you more video. See, this is very typical, dear friends. One sulci, another sulci. Center one is white matter. It is very white. Everybody can see it is white compared to this portion. Yes or no? White, black, then white, then what is this? Once again, gray matter. Then so in the center of the sulcus, you are able to see the white matter. White matter always appears white. That is the first thing will get affected. This white matter brain will enlarge in size. It will start occupying the place of gray matter. Avaga, what happens is from here to here, the thickness will increase. Now, example, if it is 8, it will start increasing to 0.9. It should be taken in a always in a same place. Once you are not taking in frontal, once no, because always you should measure it in 5 places. How to do the in the 5 places? For that, you are going to show you people. Okay, yes. So I am using the same C5 curvilinear. Light light. Yes, thank you. Okay, come here. See, once again, sir, it is all appearing white means, see here, the same thing. I use just increase the gain. Okay, see, this is called gain button. Okay, this is called a gain button. See now image. Can you see, show the image? See, it's all white. See now, slightly decrease. Slightly decrease according to you. How you want. And where is the pointer? Yeah, you want here. And you want better image. So everything you can adjust wherever, however you want. So now you understood the coronal view. Now I am going to teach you about, sagittal view. Sagittal center one is called a standard center view. Then next to that is choroid plexus view. Next one is complete para choroid plexus view, where synovial fissure is there, where you are going to see that. Now I am going to teach you about the things coronal view. In the coronal view, once again, how to keep the probe. You could learn it. See, the baby is sleeping. This is my light. This is my light. I am going to keep it. Okay. Chal. See, now I am going to show you. Now, this is my left side of the baby's brain. See, this since it is a premature baby. And one more thing. Always try to remember, dear friends, like a heart, how the apex will come in the center. Here also it should come in the center. That is the art of taking the pictures. Number one, image. Not like this, not like this, not like this. You should not take like this. Sir, I am finding. No, that angling will cause you more problem. See now, I am going to teach you. This is frontal. First one is frontal. You are not able to see anything. So this is all the whitish is from the germinal matrix around the ventricle. All the neuronal primitive or primary neuronal cells of astrocytes, gliocytes, whatever the sites, that is started migrating towards the periphery. When it is migrating towards the periphery, that time it contains more glial cells, supporting cells, and it is not completely matured. It contains more gelatin material substance and water. That is, when ultrasound is passing into that, it will appear more white. That's what in the thalamus I was telling in a premature baby. This is all frontal one. It is white. As the term baby will become more mature, water content will come down. Ultrasound passes, you don't see that. And here, if the forceps delivery is there, you can see any fracture. Okay, number one is over. Number second view. Come. See, dear friends, somebody was telling I can see corpus callosum. See, in this baby, I am coming into the center. I am not at all taking into the picture. This is the brain. You can see very clearly. I am coming slightly to the anther. See, now I am seeing the, almost I am touching to the this thing. See here, what happens, sometimes we imagine this is a corpus callosum. Okay, if you will take this. See, I can see the lateral horn of the ventricle, 1 and 2. I am not able to see much part of the corpus callosum here. I am not bothered about that. In this view, I am bothered whether this one is away, whether this one is away. If it is this one is this corner, this one is this corner, then corpus callosum agenesis. If this is not holding these two things, if this one, what I am telling once again, if this one is not going to hold these two lateral ventricles together, this fellow will go off this side, this fellow will go off this side. So here in this view, whether it is symmetrical or not, number one. Number second thing, here any previously inside the uterus, because of antiphospholipids or any thrombus, repeated abortion, repeated clotting. Okay, repeated clotting in the placenta, it is transferred to the brain and go to the MCA. Later, germinal matrix is having the hemorrhage. This can even cause a PVHI, periventricular hemorrhagic infarction, whether it is there or not. And today, Prashant was telling, if this is there, it is a PVHI. Okay, then it is cononatal cyst. And near this is germinal cyst. Next, germinolytic cyst. Okay, what is the difference between germinolytic and germinocyst? Okay, why I am telling you, dear friends, is I think so Prashant is going to take next time also, just difference between germinolytic and germinal cyst. Okay, now we will go to the third one. This is the third one, slowly coming to the cavum septum pellucidum. See, from here, lateral, I am coming slightly to the slightly opening up the cavum septum pellucidum in the center black. Center black. Okay, I am turning. Okay, this is the cavum septum pellucidum. I'm coming to the third ventricle. And I can see now third ventricle very clearly, very small. See this black one, very clear black one. This is third ventricle, where it is hyperechogenic. Compared to this portion, this is hyperechogenic. This is normal. This thalamus is normal. Nothing to worry. Nothing to worry. This thalamus, I'm telling you, this is thalamus, third ventricle, pellucidum, lateral ventricle. This portion is the one. This portion is the one, corpus callosum. And this one, not only don't see it here, here also you should see. When you are seeing the third ventricle, when you see the third ventricle, what happens? This portion is also important in the forceps delivery if there is a bleeding. If there is a bleeding, because third ventricle line, what you are seeing here, this hyperechogenicity, this is cons. Okay, sorry, this is cons. You can see here very clear an animal, cons. So this one is a medulla. So this portion is hypothalamus. Okay, this is hippocampus, hypothalamus, this is thalamus. And this is called the subsection Niagara. Why I am telling you that hyperechogenicity is there, you will know this baby will develop athetoid or substantia niagara is important for chorea. You know, that is called choroid plexus. Sorry. Yeah.
Brachial plexus.
What is that called as? Chorea type of cerebral palsy. That is the reason. Now I am going last 2 views. I know I am eating your brain. I am sorry. So I am going towards the posterior. See, this is the. Yes, I am going slowly. This is called a This is called a dance. Both the cerebellums I can see, dear friends. Both the cerebellums. This whitish is called a vermis. This whitish is called a vermis. Cerebellum. This one is. What is this called as? This one called as magna. Okay, cisterna magna. That should not be more than 10 millimeters. See, all the things. This is called a dancing lady, like a lady. You see two hands and okay, you know how they will respect. See here, if anything white here, somewhere black, you are finding that means cerebellar hemorrhage. So it is symmetrical. This is important here. This is the important thing. last one. Then glans more cerebellum. So this cerebellum, more cerebellum, everything in the center. Go to the upper mouth. And this is the place where you are going to compare this and whether this is symmetrical, both are symmetrical, whether anything. This is spherical, this is occipital. Everything I showed you. Please, dear friends, nothing is impossible. I want Kamal sir is taken a lot of effort, and even Vaideshwaran is taken a lot of effort. Please, dear friends, tomorrow next class, Prashant Gowda is going to take about IVH and hydrocephalus, ventricular measurement, Doppler effect, and how early, whether you want to watch for these ventricular measurements, how is there any method, if it is our baby, our relative's baby, you want to immediately keep on drawing the CSF and causing more puncture, for theoretically you want to learn, or if it is our baby, do you want to put the shunt emergency? So that he is going to teach you, dear friends. Over to Kamal sir and Prashant.
Thank you, sir. You just finished it very nicely, sir. You added the icing towards the cake which was made by Prashant, sir. It was an excellent demonstration of findings. And so I think we are eagerly waiting for the next class, sir, which is going to be on Tuesday on IVH and then the ventricular dimensions. How to use the charts, various charts available to calculate these ventricular index and when do we intervene, all those details I think we can discuss in the next class, sir. And sir, Prashant sir, hello.
Yes, sir. Yes, sir.
Yeah.
Yes, sir. Yes, sir.
Yeah. So
sir, when you ask a student any doubt or anything,
yeah, they
did not get it.
Yeah, one issue I had, I think it's wrong with my computer or my network. Very often the pictures are just freezing. You are talking about a different picture, whereas I am having another picture in front of my screen.
No, sir, your computers, the internet is even your picture is now cutting and coming to us.
Yeah, that's right. Our internet, I think, is BSNL.
Yes, sir.
So that is why it is sort of the quality has dropped. I'll have to change to something else now. That is why it is a very intermittent. Pictures are freezing. That is why. So when you're talking about a different picture, I'm having another picture on my screen. That is why I don't know how others are feeling. Let me see how to change this. That's one thing I found. And apart from that, it was a very useful lecture, sir. And with that, I just ask, I'll ask Prashant sir to just add a few words, and then we can close the session.
Yeah, sir. Thank you for the opportunity. It's always a pleasure teaching, and teaching is always a passion. So thank you very much for giving that opportunity. NNF Tamil Nadu and Kamal sir and Lakshmi madam, Rema madam, and Dr. Vaideshwar as well. Thank you for the entire all the attendees as well. Thank you, sir. We'll see again.
Thank you, sir.
On Tuesday, sir.
On Tuesday, sir.
Okay, sir.
Thank you, sir. Prashant sir. Thank you, Divakar sir. Dinakar sir. Thank you, sir. Thank you.
Bye, sir. Bye.
Bye.